Thank you, everyone, for coming. My name is Becky Larson. I'm the epidemiologist and deputy director at Eagle County Public Health and Environment. I've been working in public health for over 20 years, and one of my many roles is to monitor emerging public health issues really throughout the world, throughout our nation, and see what the potential is of that issue impacting our community. And one of those issues is the opioid epidemic, which I think we've all heard of in the news. We've all probably been confused about it from the news. So I want to just kind of give a brief overview of how we got here now. And really this epidemic has been going on for a while. It is not new, and it has kind of evolved. So probably in the 90s, we started seeing an increase of overdoses due to prescription opioid medication. Then in about 2010, we started to see a rise in overdoses due to heroin use. And then in about 2013, more recently, you've probably heard of the rise in overdoses due to synthetic opioids. So most of these are illegally made opioids like fentanyl. So all of those things are related to this epidemic. All of them are opioid-based, but if you think about it, we're talking about prescription drugs as well as illegal drugs. And with that, there's confusion, there's stigma, and there's 1,000 reasons of how a person has become addicted or even overdosed. So today we're going to focus just on prescription opioid medications and that role in this epidemic. And so I'm going to start off just really talking about kind of in the U.S. So we have over 2 million Americans are abusing opioid medication or dependent on opioid medications just in the United States. That's a pretty large number. And we know opioid medications play a role in pain management, but we've learned over the years that they may not always be the best medication for every type of pain, and we'll talk about that later tonight. And so we also know that they come with serious risks, and some of those risks are addiction and unfortunately even death, with 115 Americans dying every day due to overdoses from opioids. So Colorado is not immune to this. We have over 200,000 Coloradans that are addicted to opioids, and the number of prescription opioid-related overdoses have quadrupled since 2000. So that's a lot. It's here in Colorado. But the good news is, for Eagle County, is that we're not seeing that same number of overdoses from prescription medications. In fact, our rates are probably the lowest in the state, not only in hospitalizations from overdoses, but even from emergency room visits. So that's the good news. So you might be wondering, so what is this crisis about if Eagle County is looking pretty good? Well, the issue is that we know that these rates are increasing around us. We know this use and abuse is increasing around us, and we don't want to just sit and watch and wait until we're, like many other communities in Colorado, having to respond to the crisis. And we want to be proactive, and we want to prevent addiction and not wait until we're talking about hospitalizations and death. So the other kind of piece connected to this is not only the use of prescribed opioids among patients, but also the use of medications not prescribed to a person and how they have access to them. And this is an important topic for Eagle County. I just want to kind of give some quick data here. So 16% of Eagle County high school students report taking a prescription drug without a doctor's prescription one or more times. 18% of high school students thinks it's sort of easy to get a prescription drug without a doctor's prescription. So I think the concern there is that we have children who have access to prescribed opioids, even though they weren't given those prescriptions. And it's concerning because we also know that new heroin users, about 3 out of 4, report abusing prescription opioids before using heroin. And so although we might not be at a level of crisis in our community, we also have a responsibility to our community members, not only our children, but also community members who are trying to manage pain, community members that may already be addicted to prescription medication, to act. And so to reverse this epidemic, it's not as easy as just getting rid of opioid medications. I think our experts here will discuss tonight that it requires a balanced approach, and we all have a role, not only the ones sitting up here, but all of our community members as well. So I'm going to turn it on over first to Chris Vandenberg. Your mic on? Okay, she's a psychiatric mental health nurse practitioner and family nurse practitioner. She has a doctorate in nursing practice. She has over 25 years of experience in the medical field, integrating both primary care and psychiatry. She currently works as a nurse practitioner part-time for MindSprings doing medication management, and then she also has a private practice called New Beginnings Mental Health in Avon.
Thank you. I probably will not try to eat the mic because I can be really loud. So can you hear me in the back okay? So I want to start out by telling you a story. And I want to tell you a story about a 16-year-old girl. This girl never exposed to any drugs or alcohol, good student, kind girl, did everything pretty right, goal-oriented, never in trouble, came from a fairly stable home, if you will, was provided as much as emotional support as a 16-year-old will let you give them, made good grades, no problems really at all. An endurance athlete, loves to ski, loves to run, triathlons, that's her world. Well, one day, this 16-year-old had an injury, a shoulder injury that required a pretty significant surgery. So, appropriately so, with her surgery, her physicians prescribed a long-acting opiate and a short-acting opioid, and she took the medication. So she went home, and about probably 5 to 7 days after she was on the medication post-surgery, her mom started to notice a real change in her behavior in the way that she asked for her medication. She was watching the clock. If her mom was 5-10 minutes late for her medicine, she's like, "Hey, Mom, isn't it about time for that medicine?" And her mom's thinking to herself, you're an endurance athlete. You kind of need to have this all together. What's going on? Why is this pain medicine so important to you? But she kind of blew it off, made sure to give her daughter her pain medicine. About 24 hours later, she starts thinking about it again, and she's like, she's really hyper-focused on this medication. What's going on? So she starts thinking to herself, maybe it's time I need to wean her off the medication. So she has a conversation with her daughter, and she's like, I'm trying to figure out whether or not you're really in pain. Well, you can imagine asking a 16-year-old if they're in pain when they want to be in pain. So she looks at her mother, and she's like, "Why are you asking me these questions?" And her mom goes on a scale of 1 to 10, where is your pain today? And she's like, "Mom, seriously? Come on, the doctor gave me these pain medicines." So her mom, lo and behold, gives her pain medicine, goes to bed. The next day she thinks about it, and she's like, "You know what? I need to wean her off these medicines." So she goes to her daughter and she says, "Okay, you've got 2 hydrocodone and 1 morphine left." And her daughter cuts her off mid-sentence. She's like, No. I have 6 hydrocodone and 4 morphines left." So you can imagine her mother as she sits there and goes, "What is happening right now? Why, again, are you so hyper-focused on this?" So her mom sits back, looks at her daughter, and asks the question, "What is it about this pain medicine?" And her daughter kind of looks down, a little bit remorseful, maybe a little bit guilty, but mostly confused. She's a 16-year-old girl, and she doesn't really understand. But what she says to her mom is this: "Mom, I really, really, really like these medications. And I really like them so much that you probably should take them away from me. And Mom, I really like them. I like them so much that I probably should never have them again. And Mom, you know what? This is really scary for me." It was at that moment that her mother realized she wasn't addicted to medicine. She hadn't developed a tolerance to the medicine, but she had some type of emotional connection, some emotional response to this pain medication. So her mother sat back and thought, what is happening? What do I need to do? So her mother, me, and my daughter, beautiful 16, now 17-year-old daughter back here, had a great conversation. She said to me, "Mom, this is scary. If these medicines make me feel so good emotionally, what's happening?" And we talked about the dopamine response and how they release that chemical, the feel-good response. And I told her, "You're starting to experience exactly what people do when they first start to develop an addiction to pain medicine." How scary for a mother, me, and a 16-year-old girl. So she asked me this question. I work in mental health, have for many years, so my daughter's been exposed to hearing about anxiety and depression her whole life. And she says to me, "Well, Mom, if these medicines make me feel so good, how about your patients, the ones that have depression and anxiety? What happens when they have surgery and they get this medicine? What happens with them? Do they become addicted to it?" And so I looked at her and I said, "Some of them do, absolutely. Because that feel-good response, that dopamine response, actually feels really good." Interestingly, there's a reciprocal relationship, though. Addiction feeds mental illness, and mental illness feeds addiction. So this has always been a hard issue for me in my practice. Many of my patients, is there a place for pain management? As she spoke about, absolutely. But we have to be very vigilant. There's new evidence from very reputable places, Harvard, Yale, UCLA, St. Louis, that say 10% of people who take an opioid for 30 days or more with no history of depression actually start to experience depressive symptoms. Absolutely, a huge statistic. So again, here we are in this reciprocal relationship trying to find a balance. So that's my story that I wanted to share with you. I have many more. I'm very excited to be here tonight. Mental illness is my passion, caring for those of you dealing with depression, anxiety, suffering from what we call dual diagnosis, addiction, along with mental illness. So I'm here to answer any questions and help support the community in any way that I can.
Thank you, Chris. Next, Dr. David Rudham is going to speak. He is an anesthesiologist with the Anesthesia Partners of Colorado. He did a fellowship in acute pain management, and that's also his specialty.
Well, thank you very much for having me tonight. I want to talk about the 3 most commonly asked questions that I receive when I take care of people for their acute pain management. And the first question is, if opioids are so dangerous, why are you asking me to take them in the perioperative setting? And by perioperative, I mean before surgery, during surgery, and after surgery. So opioids are part of a pain management plan. They are not the entire pain management plan. Big Pharma, up through the 1980s, 90s, and 2000s, taught us that us in the medical community as well as non-medical people, that opioids were the be-all, end-all of pain management. As long as you received an opioid, you were receiving pain management. If you were not receiving an opioid, you were not receiving pain management. And that's really not true. The same thing happened with antibiotics. I like to use this as an example. With antibiotics, Big Pharma wanted everybody to think if you have a cough, cold, fever, you should be on an antibiotic. Quickly, we realized that that led to overuse of antibiotics and led to resistance. The same thing is happening with pain management. And all pain management is not the same. There are many different types of pain that need to be addressed with different drugs. And if you overuse pain medicine or overuse it inappropriately, it leads to ruined lives, addiction, and death. So this is something that we need to take very seriously. So again, opioids are part of a pain management plan. They are not the entire pain management plan. So when I see somebody in the hospital, I need to assess what kind of pain they're having. Again, because different types of pain are treated with different types of medication. So I will talk to the patient, I'll examine them, I'll hear about their prior pain experiences, and if they've had surgery, determine where and why they are having pain. So I'd like to use a total knee replacement as an example, since many people in the community have either had one or know people that have had one. So with a total knee replacement, we have basically 3 types of pain. You have pain from cutting the bone, the femur. You have pain from the soft connective tissue around the knee. And then you also have pain from the swelling induced by the surgery. So for bone and soft tissue related pain at rest, an opioid does a good job at treating that pain. That pain typically persists for about 3 to 5 days after the surgery, but again, it's just pain at rest. As soon as the patient starts moving, opioids don't do anything for that pain. So for pain in connective tissues and bones on movement, we need to use different medications. And the medications we use for that are Tylenol, a non-steroidal anti-inflammatory medication like Celebrex, ibuprofen, Advil, the medication Lyrica, as well as local anesthetics. So these medications help with pain on movement. They don't do as much with pain at rest, but they help with pain on movement. And that's the majority of pain after a total knee replacement, as well as many other types of surgeries that people will experience. Lastly, people have pain due to the pressure and swelling from the surgical incision. That also is managed with Tylenol, ibuprofen, Lyrica, local anesthetics, in addition to non-pharmacologic treatment like applying ice, performing physical therapy, and elevating the extremity. Back in the 1980s and 90s, we only used opioids for pain management after a total knee replacement. And what we found was people that were sitting in bed were relatively comfortable, again, because opioids take care of pain at rest. But as soon as that patient started doing physical therapy, they were terrifically we medicated them more with more opioids. But we found, gosh, this just isn't working. And unfortunately, as physicians, we thought, well, it's just a matter of milligram amount. We need to give the patient more. So what did we do? We gave them more medication. They were still in pain, but we gave them enough medication that they then became sleepy and were either unable to tell us they were in pain or they were asleep and their brain was still experiencing pain, but again, they were asleep. So we didn't do people any favors by this, and unfortunately, we've realized that, gosh, there are many different kinds of pain, and by using many different medications in smaller dosages, we can minimize the side effects and maximize the patient's pain control. So again, opioid monotherapy is really not indicated for nearly any procedure. It's a multitude of medications, of which opioids sometimes are a part. There are many different types of pain that you do not need an opioid for, but many of them you do. But you typically always take them in conjunction with something else to maximize your pain therapy. In addition, by this example, and this is kind of what Chris was talking about as well, if we optimize a patient's pain in the first 24, 48, 72 hours after the surgery, we can quickly stop them from taking opioids. As Chris suggested, at days 5 to 7, a transition occurs where people can safely take opioids for less than 5 to 7 days and not be at a very high risk for having to take them up to a year later. At the 5 to 7 day mark, a transition occurs, and people that take opioids for longer than 5 to 7 days really have a much higher risk of being on an opioid up to a year later. So in acute pain management, we try to manage the patient's pain optimally in the first 24, 48, 72 hours so they can rapidly titrate off the opioid. And again, back to the total knee replacement, most people after a total knee replacement have bone-related pain at rest for about 3 days after the surgery. So if we prescribe an opioid and use that for 3 to 5 days after the surgery, you can rapidly stop it. That pain on movement typically lasts about 2 weeks, and for that, you can continue to take the non-opioid management like Tylenol, ibuprofen, Lyrica, and local anesthetic. So that's the most frequently asked question I receive. The second most common question I receive is, if I take opioids, will I become addicted to them? And in the post-surgical time frame, that's a tough question. So first of all, if you take the opioids for what they're intended for, which is pain management, I'm talking functional pain management, so bone-related pain management, connective tissue, soft tissue. If you take that as prescribed for less than 5 to 7 days, you have a fairly low risk of becoming addicted and taking that pain medicine for up to a year later. Now, where we run into problems is when people are taking the opioid pain medicine for reasons that are not related to the bone-related pain. And this is what Chris was talking about. If opioids didn't have these side effects or other properties, we wouldn't even be having this discussion. But unfortunately, they do. And many people don't understand why people abuse opioids. The majority of people that take opioids after surgery, they may feel a little dull, they may feel a little sleepy. That is a common side effect of opioids. But there are certain people that feel energized by opioids. They feel as if some longing or spiritual ennui has been solved or has been taken care of by taking opioids. And therein lies the problem. Also, other people take opioids because they want to induce sleep. So you've just had surgery, whatever part of your body is uncomfortable, the stress response is active. Many people have problems sleeping after surgery. Taking an opioid to induce sleep after surgery is not a proper indication of the opioid. That is using an opioid outside of the compliance of what the physician has ordered. That increases your risk for addiction because you have problems with sleep now, you're probably going to have problems with sleep going forward. So while the opioid makes you feel really good about yourself and allows you to sleep in the short term, you're creating a very much of a long-term problem. And after a few days, that opioid is not going to give you that same sense of well-being and eliminate that spiritual wasteland that you had before. It might help you for a little bit, but it's gone very quickly. So again, as long as you take opioids for the prescribed indication, which is functional pain due to surgery, you have a low risk for addiction. And again, the time period in which you should take these is less than 5 to 7 days. Because after 5 to 7 days, statistically, you taking an opioid up to a year later is much higher than if you take it for less than 5 to 7 days. And I'm not sure if people are aware, but Governor Hickenlooper just signed into effect a law yesterday limiting new opioid prescriptions to 7 days. And that's the reasoning behind the 7 days, is that statistically you are more likely to take opioids for a longer period of time if you take them for greater than 7 days. Note, this rule did not talk about the milligram amount or quantity of opioids taken. The quantity of opioids taken actually does not correlate to the risk for addiction. It's the duration of opioid therapy. So again, take the opioids as prescribed, which is for functional pain, and take them for less than 5 to 7 days, and you have a relatively low risk for addiction. Lastly, I'm asked frequently about marijuana and pain management. This is a tough issue, and I don't have a perfect answer to it. But what I can tell you is that the majority of medical studies have shown that marijuana does not effectively treat pain. So I will tell you that anecdotally, I have many patients that tell me using marijuana has reduced their use of opioids, has eliminated their use of opioids. And even some people that are addicted to opioids use marijuana as a transition medication to stop using opioids. So certainly there are people out there that have had success with marijuana, but again, our medical studies do not demonstrate that. Most likely what I think is happening is that marijuana is blunting your emotional response to the pain, but it's not treating the functional pain itself. So what I mean by that is if you take marijuana, your brain is still experiencing the same type of pain that you had before you took the marijuana, but your emotional response to it is different. Sort of, I don't care. Yes, my knee really hurts, but I don't care. Whereas other pain medications will actually decrease the pain experience that your brain is feeling And that's a much more powerful pain experience. As in, if you have a total knee replacement and your knee is really hurting and you start taking marijuana, you're probably not likely to be able to suddenly do physical therapy. Whereas if you take alternative medications, it will actually decrease your brain's experience of pain, and you might be able to do physical therapy. So on the plus side, marijuana has a low risk for respiratory depression, constipation, and many of the other opioid side effects, but likely it's probably not going to address your pain in the way that's needed these days. So, thank you.
Thank you. Next, we're going to have Dr. Stephen Goddard speak. He is an adult hospitalist and internist and pediatrician at Vail Health, and he's also board certified in medical acupuncture.
Okay, thanks. So what can we do after you leave the hospital? Oh, speak up. Can you hear me now? Okay. I need note cards because it's in 10 minutes or less. This is a far-reaching topic. What do we do about chronic pain and opiates as an outpatient? Can you hear me now? Can you hear me now? Okay, got it. Sorry. So what can we do when you leave the hospital? How do we manage this as an outpatient? And what are we doing in Vail as well? One of the things we're looking at, you can identify risk factors for opioid abuse. We're looking at screening tools for preoperative assessment right now to look at that. Risk factors for opioid abuse would include depression, anxiety, maybe even ADHD that was misdiagnosed and really is anxiety. So people on Adderall might fall into that category too. And certainly childhood trauma is a big risk factor as well. So we're looking at that. And then coordinating with surgeons and other providers in the outpatient setting to start adjunctive modalities like acupuncture, Tai Chi, Qigong healing, Reiki, which I think is a part of Qigong, yoga, the meditation, visual imagery. There's a lot of research out there about some of these topics. And so designating a time frame for introducing these modalities post-operatively or for other pain issues, for acute pain. Maybe it'll be a week later, maybe at the 5 to 7 day, maybe 2 weeks, maybe a month if you're not off opiates. Or maybe some patients, selected patients right from the get-go post-operatively, or self-selected patients who want some additional modalities, which I'll discuss a little bit in a bit. There is the treatment goal for acute pain is also, besides pain control, to reduce opiate exposure. So and there is a study on knee replacements of using acupuncture post-operatively that's been well accepted by the American College of Physicians, which is the academic internal medicine body nationally, that shows decreased opiate use in the hospital with adjunctive acupuncture post-operatively. The chronic pain is different. In chronic pain, the pain pathways have changed from footpaths to superhighways. That's called facilitation of the neurologic system. So part of the treatment goal then is to dampen these hyperexcited pain pathways as well, damping that down. Adjunctive modalities can help that as well. Certainly acupuncture can help neurologically for this, which I'll get to in a minute. And then for both chronic and acute pain, another strategy for managing this in the patients that don't get off in 5 to 7 days is to prevent withdrawal. Because when a person goes into withdrawal, when they experience that, they go into survival mode. And then all of a sudden, that seems to have an impact where they tend to develop survival behaviors, which become more difficult to manage. A third type of patient certainly is the patient who already has addiction or mental health issues. And as has been alluded to, a lot of these patients aren't seeking a high. they're seeking relief of their symptoms, or they describe a sense of feeling whole, feel whole. They feel so much better. So, of course, what we try to do is coordinate with mental health and for patients and recognize when patients are treating primarily emotional symptoms with opiates inappropriately. In just like using the correct medication for the correct type of pain, that's not the correct medication for that. Antidepressants or other medications are indicated. Anti-inflammatory medicines are indicated for inflammatory pain. For neuropathic pain, there are medicines that work on the nerves as well, so that are non-opiate. Excuse me. So, but pain does have psychological. Oh, sorry. This is hard. I can't chew gum. And however, pain has psychological, emotional, and physical dimensions, and emotions that do affect pain strongly, particularly fear of pain. So can affect one's perception of pain, and that can also be treated with adjunctive modalities. There are some psychiatrists nationally who are doing acupuncture and psychotherapy, and their rationale is, well, you have a certain energy disposition of a patient, and there's likely to be resistance to psychotherapy that they always encounter. By changing that energy, they diminish the resistance to psychotherapy, and they have good results, quicker results. And so that also is helpful. So in speaking about adjunctive modalities, I can't address them all in this little talk, but I can talk about a couple that I know a little bit more about. One is acupuncture, and acupuncture does affect the brain and the central nervous system. Actually, functional MRI studies show us that an acupuncture point, stimulating an acupuncture point, will activate and deactivate different parts of the brain. And that's point specific. So one point will activate certain areas, and another point will do different areas. So it's not a global effect. Also, electrical acupuncture can help activate descending neurologic pathways in the spinal cord to block pain. The low-frequency electrical acupuncture can activate the endorphin pathways. High-frequency activates norepinephrine and serotonin pathways that are descending. They activate enkephalins in the spinal column and block pain as well. So, and then there's mid-frequency. It gets a little more complicated. But here at Vail, we're currently looking at developing an acupuncture clinic. We're in the planning stages for both outpatient and inpatient consults. So that's another area to develop, I think. Just a comment about visual imaging also affects the brain. There are studies that show that if you play the piano or if you imagine playing the piano in your mind, visualize it, you activate the same areas of the brain. And so, visual imagery is very helpful as well. And I'm not suggesting that people can think away their pain by any means. But there are doorways to activating the neurologic system, neurologic functions that can be helpful. I do actually think that acupuncture is a potential doorway for more sustainable practices. And so with that in mind, I just wanted to demonstrate a Qigong technique and ask you also to participate and try this out. That has applications to pain management, which we'll get to at the end here. And so it starts with diaphragmatic breathing. The musicians and people who do yoga are more familiar with this. Put your hand on your abdomen, if you would, and then when you breathe in, push your abdomen out. And it's helpful to actually now when you exhale, push in, so you can feel what it feels like to push out when you breathe in. That's the diaphragm pushing down on the abdomen. Now, keep doing that and try to make the exhale phase longer than the inhale phase without straining. So slow down the exhalation. This activates the relaxation response of the body. This is demonstrated in the New England Journal of Medicine article in the 1990s. activates the parasympathetic nervous system. So slow down that. In fact, it's a great way to go to sleep. If you imagine all the levels of the daily stress, like 12 different layers of an onion, you lay in bed and you slow down your exhale phase, and then you breathe in with your diaphragm again, and then one layer goes away, and then you sink into the bed, and then you keep doing that repeatedly. And so that's something that is well established in medicine. This is the light bulb step. The light bulb goes on. People who can do visual imagery, now imagine when you do that diaphragmatic breathing that you're pulling in pure white, warm light from the heavens into your lungs. You may have to close your eyes. but in your mind, pull that down into your lungs. And when you are able to do that, you'll feel warmth in your chest. No kidding. And so then the next step is, and if you practice these things, just like biofeedback, we're actually entraining our descending neurologic pathways by doing this. So the next step is when you can feel warmth in your lungs when you're doing this, the next visualization is move that warmth to your legs and arms. And on the exhale, always on the exhale, move that to the legs and arms. And it's good. Try this, maybe at night in bed. Your skin will tingle, and you may feel some movement or some warmth. Someone's shaking their head. But anyway, and then now the pain application part of this. When you can pull in that warmth on your breath, pure white energy from the heavens, and feel that warmth, you can actually visualize moving that warmth to any part of your body that's painful. You can do it driving down 70 if your back hurts. Yes, I've done that. So anybody can do this. You don't have to believe in chi. You don't have to. It's using your mind to activate descending neurologic pathways, and so I think if you're able to accomplish any of this today, congratulations, because you just did that with your mind. And so now, again, I'm not suggesting that people can do this in chronic pain, but I do think acupuncture is a doorway to developing more sustainable practices. I think there's a lot of data on Tai Chi. There's a lot of data on other Qigong. There's plenty of great references for Qigong techniques. Someone asked a teacher of Qigong if he believed in Qigong, and he said, I believe in the effect it has on my body. So by using visual imagery, and also you can affect the brain activation of different aspects of your central nervous system. So there's hope down the line, but I do think that we need all these other modalities to get there. And so I'm not suggesting people think away their pain. Pain is very debilitating. It has emotional, psychological impact as well. And but I do think that we need to use all the modalities that we have and can develop in order to address some of these problems.
Thank you. I'm actually quite relaxed right now. Whit Euler is our strategic planning coordinator from, it's a mouthful, the Colorado Consortium of Prescription Drug Abuse Prevention. And
we're working on the name.
I'm surprised you haven't shortened it to just letters. Or
it doesn't help.
We'll
We've tried that one. Yeah, just the consortium.
We'll
it's a little more ominous, but it works.
So he's going to provide a great state perspective and also share all of the great things that the consortium, I'm just going to call it that, has been doing. I know that in public health, we benefit from the data that you collect and share on a county level. He's also going to share with all of us some things that we, just ho-hum community members, can do on this issue as well.
Thank you.
Yeah.
I'm the lucky one. I have a handful of slides. So it's a little easier to juggle two things when one's a remote. Fair enough. Let's skip through. Right. Who does feel a little bit more relaxed after the breathing exercise? Great. I do too. Curiosity, who do we have in the audience right now? How many prescribers, nurses, folks that are working in a hospital setting? Raise of hands. Great. All of the above. All of y'all. Fantastic. How many people are working in a behavioral health care setting? So working in a clinic. Okay. I shouldn't have excluded you from that. I'm very sorry. High school athletes. I knew there'd be at least one. How many are concerned citizens? Okay, that covers most of the rest of the group, I think. All right, got a pretty good idea of who we're talking about. I'm going to run through a handful of slides and talk a little bit about what is happening in the state and a little bit about what's happening in Eagle County. That Eagle County portion has been covered very well, so I'm going to skip through those slides extremely quickly, and I'm not from here, so I don't know this issue here as well as you all do. First thing I want to mention is that the opioid epidemic in the nation in 2015 was costing the U.S. $500 billion. And that's the newest estimate from the White House Council on Economic Advisors, a very fancy sounding name. They're from the White House. That's on par with the discretionary budget for the military in that same year. It's a huge amount in the U.S. And that's the most distasteful part of this conversation because we're talking about dollars and cents when what we're really talking about is the effect on people's lives. It's huge. And I understand that it's distasteful, and I'm sorry to bring that one up first. It gets better from here. The consortium, the terribly long name, this is about what we look like, which is also kind of confusing looking. It's just a spider of balloons. It's awful. It's a terrible thing. But each one of those circles on the outside of that diagram are levers within the state of Colorado that we can push on to affect this issue, right? So provider education, public awareness, building public awareness throughout the state of Colorado. Naloxone, which is something that we're going to talk about here in a few minutes. Some of you may have heard about that. Safe disposal of medications, which is absolutely something we're going to be talking about. Recovery, each one of those is one piece. And the consortium, I think it's important to describe it quickly as a large coalition. So we have stakeholders from different agencies across the state of Colorado, nonprofits. We're not exclusive to state level entities. We've got a number of local level entities that are members as well. And what we're trying to do is make sure that we understand what everyone is doing and find ways to tie pieces together. That's most of it. Building a handful of things here and there, but a lot of it is just building connections between existing resources and services in communities and at the state level. We'll skip past some of the data since that was covered already by Rebecca. Thank you very much for that. It's my least favorite part. And I'm going to jump straight into what some of you can do as individuals, regular community members, to address this issue yourselves. The first thing is take a look in your medicine cabinet, clean out your old medications. They've been there for a year or two for most of us. We've all had that old surgery, that old dental visit, whatever it was, and we still have some opioids or other medications, whatever they might be, left over. Some of them maybe even over the counter that are a couple of years outdated, right? Go through there, take a look, see what you can find, and visit takemedsback.org to find a safe disposal site near where you live. Those boxes will look just like the one right here in the bottom right-hand corner of the slide, large, green, and they're in pharmacies and police departments. From there, those medications are shipped off to the East Coast to be burned, so they don't end up in our water, they don't end up in our landfills or soil, they're not affecting our wildlife, and they're burned down to their base elements over on the East Coast. But again, they're dealing with the smoke, not us. So please use these. It's a great opportunity to clean your house out, make it safer for you, and oddly enough, who here has a dog? Yeah, so 30% of the calls that are received by the two main pet poison control hotlines are related to medications, pets getting hold of medications. Dogs are pretty well known for counter surfing, grabbing whatever they can off of the counters. You can also put pet medications in these same disposal boxes. That's fine, especially if they're the heartworm pills that are made to smell like bacon or whatever else to entice a dog along. It's kind of luring them into grabbing it off the counter and just getting into the container, right? So dispose of your medications and encourage others to do the same. The next is a little bit more of an ask, but you can pick up something called naloxone, which is used to reverse an overdose in that moment. I picked up mine because I do this for a living, so I have to follow my own advice. This is what it looks like. My insurance covered it. I have that middle version right there called Narcan. It's a name brand, but they've got generic versions up along the top, and they've got a really fancy one. Who here is CPR certified? All right, and y'all went through the training where the little thing talks to you and tells you when to put pads on and all this stuff. So that one in the bottom right-hand corner has some similar features. It walks you through what the steps are to rescue a person. And it's an auto-injector. So it's the fancy one. It's obviously more expensive. My copay for the one in the middle, I think, was $20, $25. It's workable. And most insurance covers it, and it's covered by insurance, including Medicaid, without a prior authorization now. The top two can absolutely be accessed the same way pretty easily. Walgreens, King Soopers, a number of different organizations and pharmacies carry that, and any pharmacy can. You don't need a prescription to pick it up, but it is behind the counter. Okay? At the state level, they've written a broad standing order, which is just a prescription that covers everyone in the state. So it says that Dr. Larry Wolk, the director of CDPHE, wrote my prescription. I feel fancy. The next thing that pairs with that pretty well is something, it's the OP Rescue application. It walks a person through identifying the signs and symptoms of an overdose in that moment, responding to it, so reminding you what those steps are. I can't remember what the steps to CPR were. I took the training, I think, a year and a half ago. I think it's supposed to be good for 2 years. I don't remember what all the steps are. This application helps walk you through that, right? Calling 911, providing medication if you have it, providing rescue breathing, and at the end, they're building in another piece to, if that person is looking for treatment, this will help you find a treatment provider nearby. So it's a fantastic free application that you can download on your phone. I've done it. Have any of you? Come on, get with me, guys. You're killing me up here. All right, the final piece is raising public awareness. There are two large campaigns happening in Colorado. This one right up here is Take Meds Seriously or Take Meds Back. Take Meds Seriously is just raising awareness about safe use, safe storage, and safe disposal of medications broadly. None of those things are controversial. They're all use your prescriptions as you've been prescribed, safely store them up and away or locked up if you can, especially if you've got children, and disposing of them safely, again, using that disposal box that we talked about. Because that safe disposal is such an important piece and there's a larger program created around it, there are specific resources created around that also, and you can find those at takemedsback.org. If you're an individual, you can share some of those pieces. If you're with an organization, you can help push that out, possibly as a part of a larger community push. The other public awareness campaign that just kicked off, I think a week and a half ago, is called Lift the Label. We talked a little bit about stigma and how that definitely impacts this issue. There's stigma around chronic pain and taking opioids appropriately, even if you're prescribed them by a doctor correctly. There's also stigma definitely around if you do develop an addiction, a substance use disorder related to opioids or an opioid use disorder over time. There's stigma around both of those things and seeking out help if you're in that situation. The Lift the Label campaign seeks to give all the numbers that we've been talking about a face and a real story from someone here in Colorado. They recorded them less than 6 months ago, again, from real Colorado people. Take a look at that website if you have a chance. Share those videos. Help get the word out a little bit. Reduce stigma and increase readiness to make some changes in communities if that's what's needed. And the final piece that I want to throw out there is a little bit more touchy-feely, and I'm not really a touchy-feely guy. It's about promoting an environment for recovery. So in all of our communities across the state, I haven't run into one yet, that didn't have someone that suffered from a substance use disorder. Someone well-known, someone maybe not. It's pretty common, though, across Colorado, across the US. I've got a number in my family, friends. I think we're all probably in a similar boat as far as that goes. What I would want for those family and friends is for them to live in a community where recovery is the end point. That's the goal that everyone had in mind. Now, some of them aren't ready, and they still need to use a syringe access program, or they still need to use their drugs, hopefully as safely as they can. That's okay. The ones that are ready for it, though, they've got the resources, including housing, a pathway to viable employment, training if necessary. They've got some way to get to that end point of being a really respectful and productive society, or a productive person in the society. Having that pathway is key to getting people into recovery and maintaining them in recovery and turning the tide on this issue. And that is it. Thank you.